placing a peripheral IV is a basic skill in medicine that all doctors and nurses should have. It's a critical skill that sometimes can even save a life when emergent access is needed. But why would you want to use an ultrasound? Again, it's a basic skill. Why bring something extra into the picture to possibly complicate it? Well, not all of our patients look like this. Frequently, our patients look more like this. They have quite a bit of subcutaneous tissue to get through, and it's very difficult to find a vein to cannulate. And not just obese patients. Sometimes IV drug users have very difficult access, or just chronically ill patients, or patients like this. Babies are difficult access in general, and when you have one with quite a bit of tissue like this one, then it can be really challenging. This is actually my baby. This is my daughter, and the reason I'm showing her is because she's a perfect example of very difficult IV access. She's got a lot of tissue. She loves to eat. In fact, her sister, who is 2 years older than her, if she doesn't want to eat something, she frequently would just say, "Give it to Avery," because Avery will eat anything. And that's great if you're a baby, but it's not so great if you have to have an IV placed. Avery got sick with botulism when she was 6 months old, and she actually ended up in the ICU, intubated, and with a central line. Now, she recovered fully. She's perfect now. But at the time, she wasn't okay. And she was a very difficult IV access patient and had to have a central line, which you can see here. Now, we know that in these situations when IV access is difficult, ultrasound can help. This is one of the best studies on this. And what they found in patients who came in and were randomized to either get ultrasound or just regular standard IV placement, the difficult patients who were predicted to be difficult ahead of time, there was a huge difference in the success rate if they had ultrasound used or not, 97 versus 33%. And not just in adults, but in kids as well. In this pediatric anesthesia study, they found that the time to cannulation is much quicker, 1 minute versus 7 minutes when using ultrasound in patients with difficult access. And the number of punctures goes down from 2.5 to 1, which I can tell you is important as a father who's watched his daughter get poked multiple times in trying to get IV access. Now, this may not make complete sense, right? Using an ultrasound, bringing an extra piece of equipment in, you'd get the access quicker. But this is a basic concept of measure twice and cut once. If you take the time to look at a patient who you predict is going to be difficult access, you're going to have better success more quickly. But what if you can't get access? Is it really a big deal? You just gown up, pull the drapes out, and you put a central line in, right? Well, actually, it is a big deal. We know that about 3% of central lines are infected, and the CDC estimates that costs about $35,000 per infection. About 8% get a clot. 3% get a pneumothorax. So over 100 central lines, there's about 14 complications, and they're pretty expensive to treat. And more important than that, there are about 1 to 2 deaths for these 100 central lines. There's a mortality associated with these complications. And we know that we can reduce central lines by training nurses and doctors to use ultrasound guidance for their IVs. This is a really great study where they did just that. They had an ultrasound guided IV training program, and what they found, you can see here, is they reduced their central line rate by 80%, an incredible number. It seems a little too good to be true to me. But if you look at other studies, there are others that have pretty similar results. In this study, Thomas Everson, they said, every patient that comes in, you can't get access, and you're getting ready to place central line, stop. Make that a hard stop, and come get us. Let us try to use ultrasound to guide an IV. And their results were remarkable as well. For 100 patients who they tried ultrasound guided IVs, when they couldn't get an IV otherwise, and they're going to go to central line, they were successful in 100 of those patients. 15 of those actually had to have a central line because either the peripheral IV blew or they needed a central line for another reason, but they still prevented central line placement in 85% of these patients. A pretty incredible number. So I looked, and in my hospital in 2011, we placed over 500 central lines. If you reduce that rate by 80%, that's 425 lines you would not place, 60 complications you would reduce, $700,000 saved, and 5 to 7 lives saved. Even if you assume you're not going to have that good of success, you're not going to be able to repeat that, what if you do half as well? That's still an incredible amount of money, complications, and important lives saved. And patient satisfaction. Patients love this. Getting poked once or twice instead of 6 or 7 times, this makes a big difference in how they perceive their care overall. And it's clearly not just about the numbers. These numbers are impressive, but I can tell you from a patient standpoint, this is a really big deal. This makes a difference. So who can do this? Nurses have been shown to be really good at this. If you look at their success rates, it's very similar to the physician success rates we talked about earlier. Emergency Nursing Association actually has a resolution saying they should be able to do this. They're qualified to do this with training. They can place these ultrasound-guided IVs. Even ED technicians have been trained to do this. This isn't just a physician or nursing skill. Pretty much anybody with the right training can do this. And I know this for a fact because I've seen even physicians be able to do this, place an ultrasound-guided IV. And if we can do it, pretty much anybody can do it. Again, remember, the studies have shown a pretty similar success rate no matter who is placing these. Now here's some good news for you if you're watching this. There are actually studies showing that this can be learned by watching a course online and then practicing on your own. So how do you do it? You have to know a little bit of the anatomy at first to be able to do this successfully. These are a few of the common veins, the most likely targets. It does matter where you go, the size of the vessel, diameter, location. This has been studied and we've got some data on it. We know that the more shallow the vein and the bigger the vein, the better success you're going to have. That makes sense. We also know from this study that the more distal you're able to place an IV on the arm, the longer it lasts. And then specifically, if you want to look at numbers, if you have very shallow IVs, less than 0.4 centimeters, those had a 100% survival rate in this study. Whereas as you get deeper, the rate goes down. And once you're at over 1.2 centimeters, the survival rate is 29%. So over 70% of those fail. So try to pick a target that's as superficial as possible. Now the basilic vein tends to be my favorite target. It runs on the medial side of the arm. It's usually a pretty big target, and it's just deep enough that IV drug users aren't able to abuse that vein. Your setup is going to be the same as your normal IV setup, except you're going to have the ultrasound machine, and you're going to need a longer catheter. You absolutely cannot use the regular 1.1 inch IV catheters. You have to have the longer catheters, either 1.8 or 2.5. I can't stress this to you enough. The reason for this is even if you do get a 1.5 inch catheter in ultrasound guided, you can see here that just the tip is in. You have to go through more subcutaneous tissue, and so even if you get in and are able to cannulate it, this tiny tip in here is going to pull out as soon as they move their arm or do something else. Whereas if you have a nice long 2.5 inch catheter, you've got a fair amount of catheter in the vein. They last longer. Also, the angle you take is important. This is the biggest issue I see with nurses learning this. They're used to placing lines at a very shallow angle, but if you do that, then you're going to use a lot of the IV catheter before you get to the vein. You're going to have much left in the actual vein. So you have to take a little steeper angle, and then you can flatten out once you actually get to the vein and thread the catheter. But by taking a steeper angle, you don't use all of your catheter up in the tissue before you get there. You really have to set up well beforehand to maximize your chances for success. This is bad. You don't want the machine on the same side where you have to look back and forth, twisting your neck to see the IV and the screen. You can have it on the same side if you can comfortably just look up and down from the machine to the IV catheter, not move your head around very much. But best, I think, is to be able to look across the patient and just move your eyes up and down to the screen and to the needle without moving your head or neck at all. When picking a vein, you first have to be able to tell vein from artery. As you can see here, the vein on the right is completely compressible. As you compress this artery on the left, it becomes more pulsatile. It doesn't compress as the vein does. You can also adjust the gain to get a better image. You see as we turn the gain down, we don't see the vein quite as well as when we turn it up. So adjusting the gain can be important. The depth as well. When you find your vein, you can see the compressible vein on the right there. Once you do find a vein, you can actually look and tell how deep it is. You can see that we have 2.6 centimeters down at the very bottom here. So the anterior wall of this vein is less than a centimeter deep. So we know what kind of success rate we'll have with this IV placement. Again, remember, the deeper you are, the less likely your IV is going to survive. Now, do you place it in long axis or in plane, like on the left, or in the short axis, out of plane on the right? There are advantages and disadvantages to both. In this study, they talk about the fact that In the long axis group, needle tip visibility is much better. You're able to see the whole needle the whole time, and they tend to advocate for that approach. However, in this study, you can see that they found the success rate was a little higher in the short axis group than in the long axis group, but not by much. In my general experience, it seems to be a little easier to learn the short axis approach, but once you get better, the long axis approach is probably the way to go. A little less risk of posterior wall puncture, which we'll talk about more. Personally, I think you should learn both. You should have both of these arrows in your quiver. The more tools you're able to have and pull out, the better success you'll have. For example, different situations call for a different approach. So this is your vein. What if your artery is right here, posterior to the vein? Which approach would you use? Well, the long axis approach would probably be more appropriate, and let me show you why. With the short axis approach, you're only seeing the part of the needle just underneath the probe. So if we look here, even though the needle tip is in the vein, the beam is hitting the back of the needle. So it looks like, when we have a short axis image, that this needle, as you can see on the left side, is still above the vein. So by the time it looks like the needle is at the vein, your needle will actually be through the posterior wall and possibly hitting that artery if there's an artery just behind it. So this is a long axis view. You can see the whole needle here, and you can see that the tip is sitting in the vein. But if you have a short axis view and your probe is back here, you're going to see the needle shaft, not the tip. So it's going to look, when you turn in the short axis like that the tip is above the vein, as you can see here. So the solution to not having this happen, to see the back of the needle tip in the short axis, is that you have to follow the tip. As you can see here, as we're placing our IV, going in deeper, when we get to the probe, it's so easy to go past the beam. Whereas what you need to do is follow the tip with the probe the whole time. By doing this, you prevent the posterior puncture and you see the tip. The other thing to do is this. As you see the tip, then you move the probe. Every time you see the needle tip, if you move the probe just ahead of the needle tip until you lose it on the image, then you know that you're never ahead of the probe. The stepwise approach is probably best. Again, you're coming in, you see the tip, so you move the probe. Tip, move the probe. Tip, move. All the way following the tip into the vein. That's the safest way to do this as you're starting out. You can also rotate the probe. If it looks like the needle tip right here is in the vein in the short axis view, you could rotate 90 degrees like this, and you can see that now definitely the whole needle is in the vein. Here's a demonstration of the short axis. And watch here, we're placing the IV, and once you see it on the screen on the left, watch their hand on the right. The probe is going to slide and move with that tip. You can't just keep placing the needle. You have to follow it with the probe all the way till you get into the vein. Making adjustments is also a key in short axis. You're going to see it appear either to the right or the left. Here you can see it appear to the left of the vein. You see it on the left of the screen. So as you're following the needle tip in, you're slowly adjusting to the right. You keep adjusting all the way to the right until you follow that tip directly into the vein. So what if your artery was to the side of the vein instead of just behind it? Which approach would you use then? Well, possibly the short axis approach at that point, because then you're more worried about being off laterally than the posterior puncture. There's nothing just behind the vein to puncture, so you're not quite as concerned about that as you would be if there were an artery just behind there. But we just covered the short axis. So let me show you how to do the long axis approach. It really is a beautiful approach. Here you can see the needle coming in just underneath the probe, and you see the entire needle the whole time as it slides into the vein. Then once it's in the vein, you can also slide the catheter off. When you cast that off, you actually see the catheter in the vein as well. This is really nice confirmation that you're in the vein, as you can see right there. Everyone sees this image and they think this is the way to go. This is definitely better than the short axis. And personally, I do prefer it, but it is a little more difficult to line up the probe, the needle, and the vein. So it's slightly more technically difficult. But once you get good at it, it's a really nice technique. And you can make adjustments when doing the long axis approach as well, just like the short axis, but they're a little bit different. In this case, when you have a nice image of a vein and you place your needle just underneath the probe and come in, if you're in the body and you don't see the needle, then you must immediately stop. And what you can do is fan to each side just off of the vein until you find the needle. And if you find that it's just lateral to the left of the vein after fanning to the left, then you know you need to adjust the needle to the right a bit. Here you see an example of this. We place the needle, we don't see it, so now we're fanning to the left, don't see it, fanning back onto the vein, back to the right, and there's the needle. So we know we're to the right, so we need to go to the left. So we're adjusting to the left a little bit before we actually advance. Now we've adjusted enough to where we're lined up with the vein, and we can follow the whole needle into the vein. So what if the IV quits working, which is not that uncommon of a situation? I already showed you that up to 70% of IVs fail if they're in a really deep vein. You can actually check that. It is a little more difficult with an ultrasound guided catheter to tell if it's infiltrated or not because they're deeper. You don't have the extravasation right on the surface that you can feel. So it's important to be able to recognize these quickly. Here you can see extravasation. See the edema within the fluid? That's an extravasated IV. However, if you go look at the IV when we're worried that it may be extravasated and you see this, you flush it and you see nice flow within the vein, then you confirm that no, this is indeed still in the vein. A few pitfalls and tips. Smaller patients are definitely more difficult. This makes a huge difference in adults, and it makes a difference in kids too, but the success rates don't skyrocket in kids like they do in adults. It's a tougher skill to learn. Also, beware of the posterior puncture. We've talked about this several times, but if you're in the short axis, be very careful. You're always following the tip and you're not looking at the shaft of the needle. Tinting of the skin can be an issue. You can see here that anterior wall is completely tinting until it pushed all the way to the posterior wall, and then when the needle popped through the anterior wall, it was already through the back of the vein. I'll play that for you again. You see that anterior wall all the way on the back, and then boom, you see the needle in the tissue just posterior. Now it's back into the vein. So the solution to this is a couple of things. If you do poke through and do a posterior puncture there, then just slightly pull back after the anterior wall has rebounded, and you should be in the middle of the vein. However, it's better not to do that though. These definitely blow more often if you've poked multiple holes in the vein. Instead, when you do see the tinting, the thing to do is to flatten your angle. For example, if you're coming in at this steep of an angle, it's very easy to press that anterior wall down to the posterior wall. But if when you're coming in, you start to see a little bit of tinting, if you flatten out, you can push into the vein instead of backwards towards the posterior wall and pop into that vein easier. Again, when you got to this point, if you were coming in, pressing this anterior wall, then you would just flatten a bit and start pressing this way so that you can pop in a little sooner and be in the vein, not posterior to the vein. There are really 3 tips when it comes to placing an IV. Number 1, the tip. You have to follow the tip. That's key when you're doing a short axis approach. You have to follow it slowly, make sure you don't get ahead of the probe, or as you come in, go stepwise. See the tip? Slide, tip, slide, tip, slide until you get to the vein. The second key is the tip. When you're doing a long axis approach, the in-plane approach, you have to see the tip, the whole needle at the whole time. You cannot advance the needle if you don't see it on the screen. And then the third key is the tip. Now I'm being facetious here saying the tip, but this really is the big key. If you get good at this, if you practice on TOFU model or just a vascular access IV model, get good at following your needle tip the whole time, then you'll get really good at placing ultrasound guided IVs. There's a fair amount of hand-eye coordination that goes into this, and if you take the time to get that down, you'll be amazed at how successful you are at this skill. It really is a skill like everything else you've ever learned. It takes some time. Don't worry if you fail the first few times that you do it. You'll get good at it. You'll be great at it, and it'll make a difference for your patients. This matters, so take the time to get good at it.